Good afternoon, and thank you for joining us. I know people are still coming in, but we'll go ahead and get started. My name is Emmy Betts, and I serve as the Deputy Director for the Injury and Violence Prevention Center here at the University of Colorado Anschutz Medical Campus. I direct its Firearm Injury Prevention Initiative, and today's presentation is part of our Firearm Injury webinar series. Before I introduce today's speakers, I have a couple logistics. So first is that we are recording this and we will send the video link to everyone who registered. We'll also put the link in the chat where you can find past webinars online. Please put any questions you have in the Q&A box. We'll be having a moderated Q&A session at the end after the presentation, and we would love to know what you want to know. And then please do mark your calendars for our next firearm injury webinar on November 16th at noon Mountain Time. We'll be talking about risk assessment, what that means from the perspective of a firearm retailer assessing whether a customer seems okay to buy a gun, all the way through how a psychiatrist considers whether firearms are okay to be returned after an extreme risk order has ended. And we'll put the registration link in the chat as well for that. But now it is my great pleasure to introduce today's speakers, who I am just so grateful to count all of them as friends and colleagues. So as the great Dr. Kuhls once said, firearm injury prevention really can be a radioactive topic. But the American College of Surgeons Committee on Trauma has really found a path through this topic. They fostered and promoted an inclusive collegial dialogue centered on how best to reduce firearm injury, death, and disability because it matters to patients. This approach has led to a common narrative and a strategy focused on understanding and addressing the root causes of violence, while also making firearm ownership as safe as reasonably possible. This common narrative serves as the foundation for very specific pragmatic steps that the college is taking and encouraging to reduce the burden of firearm-related injury, death, and disability. So today's webinar is going to present newly published data from a survey of firearm storage practices of US members of the American College of Surgeons. The presentation is going to highlight some of the key research findings, as well as the larger context in which this work is occurring. And so I'm so grateful to have our speakers here with us today. All of them are surgeons or trauma surgeons or surgeons in training who not only repair bullet holes, but are doing so much to prevent them. So our first speaker will be Dr. Ronnie Stewart. He currently serves as the ACS Medical Director of Trauma Programs and is the chair of the Department of Surgery at UT Health San Antonio. Among his many accomplishments, Dr. Stewart has served on the ACS Committee on Trauma for 20 years, including serving as the national chair from 2014 to 2018. During his tenure as chair, the Committee on Trauma implemented the ACS Stop the Bleed educational program, which many of you probably know about. It's trained more than 1.6 million people on how to control life-threatening bleeding. Our next speaker will be Dr. L. Thomas, who is the inaugural ACS COT Firearm Injury Clinical Scholar in Residence. It's a position that's also funded by a joint consortium of other prominent trauma societies. Her research centers on injury prevention and health policy with particular interest in health disparities, education, and long-term outcomes related to firearm injury. She completed her master's in public health at Yale, and she's taking time away from her surgery residency at the Medical College of Wisconsin to do this fellowship and obtain a master's degree in health sciences and outcomes research. Our third speaker is Dr. Deborah Kuhls, who's a trauma and critical care surgeon and the interim assistant dean for research at the Kirkonian School of Medicine at the University of Nevada, Las Vegas. She's chair of the Trauma Prevention Coalition, which is a group of 15 national and international professional organizations collaborating to develop effective strategies in injury and violence prevention and advocacy. And she's the immediate past chair of the ACS COT Injury Prevention and Control Committee. And I heard that the original first survey that they might mention today was originally Deb's idea. She's currently also a co-PI on a large firearm-related study that's funded by the National Collaborative on Gun Violence Research. And last, but certainly not least, is Dr. Brendan Campbell, who is the Donald Hite Endowed Chair in Pediatric Surgery at Connecticut Children's Medical Center in Hartford. And he's also chair of the Injury Prevention and Control Committee of the ACS COT. He's also Chief Surgical Quality Officer at Connecticut's Children's and the Deputy Director of the UNM Prevention Research Center. So we have an incredible panel today, and with that, I'm going to turn it over to them. Thank you for joining us.
Thank you, Dr. Betts. Thanks for all your team does. It's super amazing work, and thanks for your partnership and really for your inspiration as well. We're honored to speak today, and so we'll go ahead and get started. Dr. Thomas, if you could go next slide, please. So I think many in the audience probably know that there's many challenges around firearm injury prevention and violence prevention. Firearm injury is complex. It's multifaceted. It has many different faces, and you know, at least on the surface, there's a fair amount of political polarization. This work for us started decades ago, really for the Committee on Trauma, but in the modern approach, this 7 years ago, and it's just as Dr. Betts said that I remember a very early conversation with Dr. Kuhls and myself where basically we recognized that the topic appeared radioactive, and so we've worked on a process to navigate through that. Next slide. And we've learned that actually there's many concrete steps that we can do to make progress. Part of that is this work we're talking about. Part of it is actually just this webinar. We've realized that we can build partnerships all across the world with respect to when we have a common approach and coming together an inclusive approach to things. Next slide. And we kind of come at this from what I call trauma and emergency healthcare system development. And so I think if you go anywhere in the world, anywhere in the United States, and you have a really effective emergency healthcare system, I think you'll find that somewhere these principles are at work to be inclusive of all points of view, to involve everyone in the decision making. And then once we're inclusive with respect to those things, we talk about it, we develop a dialogue and consensus centered around what's the right thing to do for the patient or the population being served, what's the right thing to do for the patient. And wherever you find these successful health systems, I think you'll see that cooperation and communication are values in that in those systems. And even though we're inclusive, centered on what's the right thing to do for the patient, making decisions by consensus, not votes, cooperation, communication, or values, they have a bias for action to do things. And that's kind of the fundamental approach that we've taken with respect to this complex problem. Next slide. But as we enter into it, I think we just have to acknowledge that there's two dominant contrasting stories and even philosophies around firearm ownership in the US. And I think of these as the two dominant narratives, that guns are critically important for personal protection and really an emblem of freedom. And the second narrative is that guns lead to violence and in many ways limit freedom because of the risk of harm on our streets and in our homes. And we know when we ask the question wrong, we asked the question wrong in our survey initially, that if you ask a composite question, it does look pretty polar, about 40% on one side, 40% on the other, and maybe 20% in the middle. Next slide. So what's our philosophy in this approach? It's really simple. We think of it as basically a core of the professional approach, is committing ourselves to the service of our patients and our community and placing the needs of the patient above those of the physician or the care provider. And as best we can, we'll base our information on objective scientific truth as best we can determine it. Next slide. So how important is it to our patients and our communities? Well, I mean, I believe it's the most neglected, unaddressed public health problem in the United States by far. If you look at intentional violence, firearm and non-firearm related, that's 183 people die every single day in the US. Almost 60% are firearm related. These are big problems in children and adults. And it's really not seen the intentional violence and firearm injury have not seen the same improvement as traffic related injury and deaths. Mass shootings have significantly increased over the past decades, and violent injury increased during the pandemic. And it's not just the deaths, the burden of the disease are much, much greater than deaths alone. It destroys communities and families. Next slide. So I've talked about these two contrasting philosophies and stories. Next slide. Is it possible to have a common story that leads to cooperation? And I will say that you'll see that it is possible. And it's not just possible. I think at least in a group of 300 people who have very strong, well-formed opinions, I think we've proven that we can have a common story that leads to cooperation. Next slide. And that common narrative goes something like this, that we acknowledge that firearm ownership is a constitutionally protected liberty, but violence is a major cause of preventable death and suffering, as I just laid out. And we can significantly reduce unnecessary death and suffering and disability by committing to work together to do two things: to understand and address the underlying causes of violence, while working to make firearm ownership as safe as we possibly can. Next slide. As I talked about early in the opening, that we've realized that it's critically important to develop partnerships, and we've consciously engaged firearm owners as part of the solution, and we've consistently and really diligently tried to work to build partnerships across all the professional societies in the U.S. and actually outside the U.S. as well. But and I think a testament to that is, 47 organizations came together and support, a group of consensus statements that basically, if we implemented all these things, we could do a tremendous amount about reducing injury without really any policy change. Next slide. So, but with respect to policy, I think we have to ask, where do we agree? And that was one of the things that led to these surveys. I remember the discussion whenever Dr. Kuhls and I were talking about next steps, and it was really her idea to come up with this survey. And it's, we'll figure out where we agree and where we disagree. And next slide. And once we did that, we realized if we came up with such a survey, we could actually understand where we feel on policy, and we could use it as an engagement tool for our members to actually get them talking about things in a civil, collegial way. And so we started with the survey of the Committee on Trauma. We then we did other surveys, and ultimately this led to a survey of all U.S. members of the American College of Surgeons. And I'm going to turn it over from here to Dr. Thomas, who also is our first inaugural firearm scholar, and part of this, her work is part of this incredible collaborative effort. Dr. Thomas.
Thank you. Thank you. So I'll be discussing the methods, exactly how we structured the study in order to create the survey, disseminate the survey, and analyze the results. So this survey was created with the University of Illinois at Chicago Service Research Lab. And, we collected information about experiences with firearms, storage practices, purposes of owning firearms, opinions on firearm ownership, and to what extent individuals would support ACS advocacy on gun control. It was really an iterative process between the ACS and the research lab. And we also included the questionnaire review committee to ensure that the survey followed all of the ethical practices and basic principles of questionnaire construction. Because this was intended to be a census of the members rather than a sample, the entire membership of the US ACS group were invited to participate in the survey. So that included fellows, initiates, associates, residents, med students, and affiliates. After much discussion during the data collection process, retirees were actually included during the course of that. So there was a total of 54,761 individuals that were invited to participate. And of those, 10,291 active US members and 856 retirees participated for a total of 11,147, which corresponds to about a 20.4% response rate. So in terms of survey administration, on July 23rd, the initial pilot survey was sent to a group of 200 randomly selected ACS members. 23 ended up completing that survey, and all of those respondents were included in the final data set. On July 31st, the official data collection began, and this was continued over a period of 3 days because of the size of the sample. And then email remainders were sent over the 3 following weeks. As I mentioned earlier, during the course of the data collection, retirees were invited to complete the survey. And so at the September 14th, retirees were invited to actually complete the survey. There was a non-response survey performed on the current ACS members just to kind of see where we were at, how much longer we needed to keep the survey open, and do all those calculations. The survey for the official group closed on September 19th, and then the survey for the retirees closed on October 8th. Analyses were performed by the UIC Survey Research group. We wanted to really ensure impartiality in our data analysis. They performed both descriptive analysis and hypothesis testing, but due to the large sample size, nearly every test was statistically significant. So we opted to only describe and perform a descriptive analysis. To calculate sample weights, we looked at the demographic variables of the survey respondents. We wanted to determine the differences in response propensity. So whether or not you were more likely to respond to a question was based on some very specific variables. And those variables were membership type, region, gender, and age group. So all analyses were performed and reported on the weighted sample. And I will hand it over to Dr. Kuhls.
Yes, thank you, Dr. Thomas. So I'm going to discuss the results. We can go on to the next slide. So I'm first going to just describe our respondents. So as we can see, about 75% of them had already trained in surgery, so they were no longer trainees. We had about 21% who were residents and medical students, and about 10% retirees. Go to the next slide. And if we look at gender and ethnicity, we had about 21% female and 78% male. Just going to make a comment on this slide that in our, Dr. Stewart mentioned our prior surveys, which were based upon smaller sample size. We had very few females, and we had very few non-white participants just due to the makeup of the group. So in this sample, when we look at race and ethnicity, we had 77% white or Caucasian, and the remainder were diverse. So we are very happy to have a more diverse population. Next slide. When we look at age groups, they're pretty well distributed. We also looked at military service, and we have about 21.6% who had some sort of previous military service, whether they were active duty, reserves, National Guard, however they described their military service. Next slide. And when we look at where they are in terms of urban versus rural or frontier, we found that approximately 62% were from large cities or suburbs, and the remainder from smaller cities, rural, and then we had about 10% that were not in clinical practice. And I didn't mention geographic location, but they were geographically well distributed. So we can go on to the next slide. So I'm going to talk a little bit about some of the questions that we answered. I'm going to start off with actually 3 questions that were about personal opinions about firearm ownership. To the left in the blue bars, these were answers to, is firearm ownership beneficial or harmful. And we could see that about an equal number of people felt it was beneficial or harmful. But then you had, almost 50% saying it was both, and a little less than 10% saying it was neither. So, so these were very interesting results to us. On the right, in the red bars, was a different question. Does firearm ownership protect or limit personal liberty? And this relates to Dr. Stewart's earlier slide. And we can see that many felt that it protects, a little over 40%, less than 10% felt like it limits. And then again, you have this large number, nearly 45% that neither, and then some that had no opinion. I didn't report here the third question, but that was, is firearm ownership a constitutional right? And about 73.7% of our respondents felt it was a constitutional right. 9% were uncertain and 17% said it was not. So we can go on to the next slide. We also ask a question of, basically, is this a question that the American College of Surgeons should address in terms of policy initiatives that could decrease the incidence of firearm injury? And in this slide, I sort of look at male and female, and we can see that we use a 5-point Likert scale. When we look at mean, 1 is not at all important to 5 is it's extremely important. The same Likert scale will be used for the next few slides. We can see that people who identified as female had a mean of 4.5 and men had a mean of 4.0. We can go on to the next slide. Then if we look at the respondents again, by those who had firearm in the home and those who didn't, and we used firearm in the home as a surrogate, if you will, for firearm ownership. And we can see that the results are somewhat varied, so that those who had no firearm in the home had a mean score of 4.5 versus firearm in the home that had 3.6. But just to kind of review the Likert scale, 5.00 would mean it was extremely important that the College of Surgeons identify this issue, 4 very important and 3 moderately important, so that even a 3.6 mean is still important. So next slide. This next slide looks at kind of a composite of 25 possible legislative or policy initiatives. We're not going to have time to go over all of those, so I'm going to present the composite and a little bit more granular information. So we can see that if you would click, this is an animated slide. So the mean overall for all 25 possible initiatives was 4.1, again, using the same Likert scale. And if you could click again, when we look at those who felt it was extremely or very important, that was 75% of respondents, and 14% felt it was not at all or slightly important for the American College of Surgeons to address. We can go on to the next slide. So again, I'm going to give you the reference so you can look up all of the individual details, but the initiatives that had the highest support were included in several categories. The first was mental health, and there were a few questions on this. Preventing those with really serious mental health issues, from being able to own a firearm to improving mental health services. These were rated very high. The next was really increasing penalties for those who really shouldn't be owning firearms and enhancing the background check system and its applicability to all types of purchases. Next was firearm research funding, followed by evidence-based injury prevention programs to decrease firearm injuries and death, firearm safety training, preserving the right of healthcare workers to counsel patients on safe firearm ownership. So these are the areas of greatest significance. 16 out of 25 had a mean level of support of 4.0. So we felt it was very supportive. Go on to the next slide. Kind of in summary, if we look at the composite response of members, 75% of members that responded support firearm injury prevention and advocacy. There's broad agreement without significant polarization on several of these issues. The areas of disagreement we look at as opportunities for partnership and further exploration. And kind of reflecting back on the personal opinion responses that we got and how varied they were. Despite the differences in personal opinions, there really is broad consensus in many of the advocacy and policy initiatives that will allow us to really address some of the root causes of firearm injuries and deaths in the US. Here's the reference to the article, and we can go on to the next slide. This is a visual abstract of this particular article, and it recaps some of the same information that I reviewed, and it gives a little bit more granular information on the areas of consensus. Thank you for your time, and next we'll go on to Dr. Campbell.
All right, thanks for that, Dr. Kuhls. So what I'm just going to briefly do over the next 6 slides or so is talk a little bit about a subset of the data from the study that Dr. Kuhls just described for you, looking at the subset of American surgeons who own firearms. Next slide, please. So I think one thing that is really important, and this gets back at Dr. Stewart's slide where he talked about guns leading to and being an important part of the American psyche and the importance of protection and freedom. And this really has a historic significance in that in colonial times, Americans were very dependent on firearms for not only survival, but for protection. And this quote from Rick Atkinson's recent book sort of gets at that. Next slide, please. So I put this in there because I love this quote. Every complex problem has a solution which is simple, direct, plausible, and wrong. And I think this is very much true when it comes to trying to understand and prevent gun injuries in the United States. I think when you begin to address this problem, you think all we have to do is educate people on the dangers of firearms and they'll change how they store them, how they handle them. But that is not always true. And you have to understand why people own guns and their reasons for firearm ownership to get at this. Next slide. So I think one of the things, and this is a very well-written paper that I would highly recommend to anybody. I don't consistently read perspectives in psychological sciences, but this talks about the 2 reasons which motivate people who own firearms for personal protection. And that is, 1, the world is a dangerous place, which I think we would all agree that it can be at times. And there's a concern that many of these individuals have that the institutions we have and the systems we've put in place will not protect them. So that motivates them to own guns. And I think this is particularly important with the trends we've seen, not only for the surge in firearms sales that we've seen during COVID, but also more and more people are buying handguns for personal protection, and many fewer people are buying long guns for sporting and hunting purposes. Next slide. So when we looked at the subset of American surgeons who belong to the American College of Surgeons who own guns, these were some of the trends that we saw. If you're Caucasian, you're more apt to keep a gun in your home, and you're more likely to keep it unlocked. And if you are a minority, you're less likely to have a gun in the home, and you're less likely to keep it unlocked and less likely to keep it unlocked and loaded. Next slide. And there were 2 trends you see here. So those surgeons who had military experience or were retired were both more apt to keep a gun in their home and more likely to keep it unlocked and loaded. And I think this is grounds for a little bit of positivity from these results. If you're a female and if you have children in the home, you are less apt to have a firearm and less apt to store it unsafely. So this is alarming, but in some ways encouraging, because two of the things that there are two subsets of American surgeons who are less apt to store a gun in an unsafe manner. Next slide. And this is just, a summary of what I have just presented in a prettier way that the Journal of the American College of Surgeons helped us put together. And I think the two take-home points here that generate additional questions for us and hopefully will stimulate some of the discussion, which will be coming up, is that a significant number, 42% of American College of Surgeons members own firearms, and nearly a third store them loaded and unlocked in their homes. You can see on the right some of the reasons for ownership and the types of firearms owned, and some of additional information on safety. And I think that's my final slide. Go ahead to the next one, Dr. Thomas, and I think that's it. So looking forward to the discussion and hopefully some interesting and exciting questions from the group.
Thank you so much. That was really a wonderful, interesting overview and leaves us plenty of time to chat, which just as we planned. So while the audience hopefully is going to start putting some questions in, I have a couple questions for each of you. So first, for Dr. Campbell, what do you see as the next step in this work, particularly around surgeons who own firearms themselves?
All right, so that's a great question that you're asking, Dr. Betts. And I think from our perspective, there are a couple of things we want to know. I think we need to develop a better understanding of why surgeons, we know why they own them, for protection, for hunting, for collecting, and those types of things. But I think we need a more granular understanding of their reasons for ownership, because it's only once we have that understanding and talk to surgeons about it that we will be better able to design interventions which may make them store their firearms more safely. And I think the critical thing, and no one knows this better than you do, and one of my favorite papers ever written on this topic relates to cultural competency. And knowing how to approach patients and friends, colleagues about this issue. You can't just go in with preconceived notions. You have to understand the people you're talking to. And once we're able to do that, I think we'll be better able to design interventions that people might actually do to make firearm ownership as safe as possible. And Dr. Stewart deserves a lot of credit, because a lot of people go into this and don't want to engage the firearm owners. And if you want to be successful and if you want to make progress on this issue, you absolutely have to do that.
Mm-hmm. That is a wonderful segue, and thank you for the very kind comments. I'll send you your check afterwards for that. But, so Dr. Stewart, I hear from people too, sort of that, well, it's collaboration. How can we this seems impossible. It's this radioactive topic, et cetera. How do we do it? Can you talk a little bit more about your experience in these programs over the years, particularly in engaging firearm owners in the process?
Yeah, it's a pleasure to talk about it. In some ways, I think the people on this call, I think on this conference, I think in some ways, probably as a collective group, we've probably talked to more people on, both sides of this issue than probably many people in the country. Certainly in healthcare, I think we've, and I have talked with people in, Little Rock, Arkansas, and West Texas, and also Manhattan and Providence, Rhode Island, and I would say that the common narrative, in ways, it was an intentional common narrative, that we realized that we could actually talk to a group of people who were predominantly firearm owners and who really maybe own their firearms for protection. We could talk, we could engage them, and it was a good discussion, and we learned a lot, and And we could do the same with respect to people who really, tightly hold the firearm and violence narrative. But we didn't exactly have a common thing that we could do that would naturally lead to action. So we intentionally borrowed from those discussions. We intentionally borrowed from those discussions to come up with something that we've called the inclusive American narrative. And I would say that approach, really, I feel pretty confident that if somebody really believes in that narrative, that you can talk to people across the entire spectrum, and you can do it in front of Congress, in front of and so I think it's been a great experience. I think we've learned that it was radioactive in a way, but we've learned that it doesn't have to be radioactive. That if we approach it with the way that I think we're as physicians, if you think about the professional model, it's basically what we're taught. And I think approaching it in that way leads to partnerships where you can have, and I do believe this is true. I don't think I'm just overly optimistic. You can have people who love guns and people who hate guns, and they actually can work together side by side, creatively coming up with better alternatives. And so I'm very optimistic about that approach. And I think as we've all said, I think that in many real ways embodies your work that you, I mean, it's and there, there's a group of people across the country who have taken on this similar approach. And so I think I would just say, I feel quite good about it and safe about that approach. We've learned cultural competence with respect to kind of, as Dr. Campbell said, we've learned, we've learned that words matter, and we've learned that actually partnering together, we can actually make a difference and do things. And I think that engaging firearm owners and engaging also communities at increased risk, communities in our discussions with both of those communities often feel sort of stereotyped and stigmatized in a way. And so I can't say enough good things about the approach, that it's led us to understand that we can, a philosophic approach where we can actually work together and make a difference, hopefully long-term make a difference.
Oh, yeah, thank you for that. Changing direction a little bit, specific question about this, about the study itself. For audience members who may or may not be familiar with firearm storage options, there are sort of rapid access devices like lock boxes that can allow a weapon to be stored loaded but locked, but able to be accessed quickly. So the question is whether you had any data about this, for example, the type of locking device. And then a related question, for the people who have the loaded and unlocked weapons, do you know how many of them lived alone versus with someone else?
So those are excellent questions. I think one of the challenges with this type of study, when you're sending it out to each and every member of the American College of Surgeons, is that it has to be a manageable study, that people aren't going to get a third of the way through and just give up. So it was intentionally concise and limited. So as far as that goes, those questions we don't have the answers to, but those will be part of the next steps and very important to get at. I think another important contribution that Dr. Stewart has made to this issue is we have a firearm strategy team of the American College of Surgeons. And these are surgeon, gun owners who are passionate about firearms for a variety of different reasons. and getting their input and using them as trusted messengers, as Dr. Stewart says, because we're not going to get anywhere if we don't engage those people and sort of get a better understanding. So, but to answer that question, those are absolutely valid and important questions that hopefully we'll maybe be able to present at another webinar like this in a year or so.
Super. Next, I would love to turn over to Dr. Thomas. You, as we've mentioned, are the inaugural firearm injury clinical scholar in residence. And if I remember correctly, I think there might be applications open now or open soon. I was hoping you could tell us a little bit about the program, what's involved, so that hopefully the audience can also spread the news and we can get more fantastic training opportunities for folks.
The application is most definitely open, welcoming all people who want to do this kind of work. So what's involved as the firearm scholar? I would just like to highlight two things. So the structure and the support. So the way that this program is structured is that we have a relationship with Northwestern. And so I am kind of embedded with the Northwestern Clinical Fellows through the program SoQuick. And that's kind of how I get my master's degree and how I'm able to fellowship with other similar scholars. And then I'm at the college, essentially. And through that, I get to interface with, people like the biostatistician that works with TQIP, with all of the leadership and with all of the people who have been doing this work for a very long time. And I'm able to kind of make this my own. I'm able to work on the projects that I'm most interested in and work on the projects that I think are, more geared toward my skill set and developing all the skills that I want to develop. And then so I think that was kind of the brilliance of the way that this program was developed. And I mean, naturally, I always say I started in the pandemic. And so I got to, I got everyone who was already very much so virtual and very able and willing to communicate and collaborate across the nation. But I think part of this project, part of this program, because you're working with such fire kind of powerhouses in the field, you get to, reach out and be part of projects across the nation and really ask, people questions about your own projects and get everyone's kind of input. And it's been a kind of a really beautiful program. And a couple other things that you get some student mentorship, you get to mentor students through projects, you get to have your own educational advancement, and you get to have professional development through, attending conferences and giving presentations. So it's kind of the whole package, and it's structured in a way that you get really hands-on mentorship.
We so need to continue training in the next generation of researchers and folks trained in advocacy and leadership in this space. I'm curious, this is a little bit off script, but I promise this is a friendly question. So as I was listening to you all speak and thinking about your clinical jobs and my clinical jobs, and we've certainly had it feels like a big uptick in violence in Denver, although I don't have numbers specifically on it, but we've had a lot of gunshot wounds lately. This what feels really like just senseless tragedies, and that what we do on our clinical work, for many of us, I think the reason we do the prevention work is because it's a bit of a resiliency approach, I guess. But I'm curious if any of you have any specific thoughts on that, sort of how you also balance out when you're sort of collaborating with groups, but then might see something in a clinical space that makes you sometimes even angry that guns exist, for example, after horrible tragedies or things. I'm curious if any of you have any comments on that.
Yeah, so I think it's an interesting sample we have on the webinar. I think in real ways, we've got just of the people who are on the webinar, we have people who've cared for some of the largest mass shootings in the United States, and I mean, if you think about them, and also deal with the everyday toll of violence and firearm violence. I do think I feel similarly to what you said about resiliency. I think, getting there's getting to root causes and actually really trying to work to make a difference in a way that's not superficial, I think is really helps with resilience and really helps with avoiding burnout in the space. I think trauma-informed care, another thing that we've learned is that trauma-informed care is a really important part of that. And I don't think trauma-informed care in the trauma community, the physical trauma community, would be as far along without this work. So I would encourage everybody who's in acute care to work together. And then as far as the gun itself, as far as that, I think as I've said, I think I've learned that actually the best way to really make a difference is to work with people who are the most, who actually are the firearm owners themselves, and to engage them in a way that makes firearm ownership as safe as possible. To me, I think that's really the only path forward. And I think we can easily get to policy if we engage responsible firearm owners. There is, I think, a culture of inherent in the large group of firearm owners of responsible, safe ownership. And obviously we continue to appeal to that. And I think once those voices are heard, I think change happens naturally.
Yeah, I'd like to make just a couple of comments. I think that our own personal resiliency is really important. And when we look at the diverse issues surrounding firearm injuries and deaths, and firearm owners and non-owners and people with various backgrounds, I think if we keep our eye on the patient, and firearm owners, whether they're surgeons or my brother, no one wants people to get injured and killed by firearms, and so I think that's a really unifying thought. That's also unifying with respect to advocacy. Dr. Stewart's exactly right. You can talk to Congress about that. As a matter of fact, he has done that on multiple occasions very effectively. And so I look at that as one of the really unifying forces. So we as physicians, we care about our patients, right? So we need to learn how to talk about this topic, how to keep them safe. As we all know, many times the circumstances of an individual shooting are unclear. So an approach that our patients know that we really care about them. And if there is anything that I like to have an open discussion with my patients in retrospect, was there anything that they might change, in their future encounters in the world to keep themselves a little safer, or was it something that just was not able to be anticipated? Among people who come to us with suicide and suicide attempts, who come to medical care, whether they come to the emergency room, they come to a trauma surgeon, I think it's just really important that we have a discussion with them and their family about, do they have firearms in the home? Sometimes it's obvious because that was the mechanism, but other times it's not. So is this a safe device to have in one's home? Among older people who I think some of the statistics on the retirees are among the scariest for me, because I imagine that their grandparents, they have grandchildren visiting, and we all know that there's no sadder day than to have to tell parents or grandparents that their child or their grandchild has either accidentally shot someone or him or herself, or intentionally done so. So starting to really have those conversations, I think, is incredibly important. I also wanted to comment on a question that was asked earlier And that's if we know if people who live alone are more likely to have a gun loaded and unsecured. We didn't ask that question, but we did with respect to children in the home. And it's nearly half. The percent is 21% of surgeons who, I guess it's 21% of those who have children in the home leave a gun unsecured and loaded versus 38%. So it's almost half. So whether there's a child around makes a difference. We didn't ask whether they live alone. We might be able to reanalyze some of the data to get a proxy for that. So, thank you.
Oh, Deb, Dr. Kuhls, before you turn off your mic, though, I have one other question for you. You all kind of touched on this, but I'm curious what you guys see as the next step in this work. So separate from the research, sort of what's up next for ACS? And you mentioned Congress a couple times. You guys going out on a road show. Yeah. What's the next? Is there new education sort of planned as part of surgery residencies? What do you see as the next couple of years?
So certainly firearm safety training, I think, is a huge initiative, and Dr. Campbell's more involved in that than I am. But I think there is a real need for safety training in order to protect ourselves and those around us. And I really think that in addition to some of the other items that we've talked about, the role of advocacy is really, really important. And to work through our professional organizations or just as individual citizens to look at some of the root causes of violence. So there are some active bills in Congress that would help to fund violence, intervention and prevention initiatives. And as we've kind of grappled with this large issue, violence is really appears to be one of the root causes, and there are many contributors to violence, but some of those initiatives we feel are very, very promising. And so I think the role of advocacy is not to be underestimated. I think it's extremely important.
And then I would just piggyback on top of Dr. Kuhls, and that from the working to understand, address root causes of violence, the iSave group, we have two work groups, the Firearm Strategy Team and the Improving Social Determinants to Attenuate Violence iSave group. We'll work to implement those recommendations, which is have a trauma-informed care curriculum for all trauma centers, work I think that trauma-informed care initiative will bear fruit on its own. To advocate for health systems. We have, a lot of our health systems are affluent, and for those health systems to invest in the communities they serve, particularly those disinvested communities where there's endemic firearm violence and violence, to invest in those communities. And the third thing is to work to integrate social care into acute care. It's a whole long story, but that's along the lines of hospital-based and community-based violence intervention programs, working for peer support, part of trauma-informed care, to make that a reality. And so we'll work to do that through obviously multiple different ways, but one of the ways to do that is through the criteria for trauma centers, for trauma center verification, to work with those trauma centers. That's a strength of the COT's approach, is it sort of almost has implementation built into it through the network of trauma centers. So that's some of the things that are next.
Mm-hmm. That's wonderful. Thank you. And Dr. Campbell, Dr. Kuhls just mentioned you're doing some firearm safety education pieces. Can you comment a little on that? There's a question also from a physician and firearms instructor wondering about sort of opportunities for training healthcare on these topics.
Right. So I think there's cause for hope here. I think it's very easy to get a little bit depressed and frustrated when you're seeing patients with these types of injuries. But I think there is opportunity. And I think the one thing that we've learned in our work is that there is, universal agreement on both sides of the issue that we need to do something. And I think what's really important is that, we're all working in a time where the resources we have to do what we need to do are limited. So it's critically important that we identify things that work. If we're going to do something, we should know which population it's going to work in and what type of intervention is going to work. And those are the things that you're doing. We're seeing more monies become available to fund these sorts of projects, training the next generation of injury prevention scientists. Dr. Thomas is a wonderful example of that. She's done an extraordinary amount of work over the last 14 months and has been a pleasure to work with and see her grow. But specifically, things that we're doing with gun owners, just as one simple example, I'll tell a little bit of a story because I think stories sort of bring the point home. We were teaching Stop the Bleed at a gun club. We were in some ethnic home where we were, where there was this local gun club outside of Waterbury, Connecticut. And one of the neurosurgeons I work with, who's a gun owner, said, you know what, I want to talk about suicide and safe storage of firearms. And I was like, oh man, this is either going to be really good or really bad. But here was a trusted messenger, a surgeon, retired military, gun owner himself. And as we launched into the Stop the Bleed class, he asked the audience to raise a hand if you know someone who's taken their life with a firearm. And nearly every member of the audience put their hand up, and you could hear a pin drop. And then he launched into a very appropriate discussion about recognizing friends, family members, colleagues who were feeling depressed and might have access to a firearm, and how it's important to say something. And what was almost, gave me goosebumps was I was leaving, I had 3 different people come up to me and say how important this was. And one guy, in a very colorful way, said, I don't give a damn what the National Rifle Association says. This is important and we should do it because it's the right thing. So, it's stories like that that give me hope and motivate me to continue this work, because we can make progress. We're not going to prevent every suicide and every firearm injury, but we can certainly do better than we've done in recent time.
Well, that feels like maybe a perfect note to leave it on, because I think you're right. There is a lot of hope. We have a lot of work to do and we need help from other people out there. But I think you all are really leading fantastic efforts, and it's great to see more medical organizations and public health groups following suit. Thank you all so much for your time today and your comments and for the work you're doing. And thank you to our attendees for coming today. And we hope to see you in November. Thank you and be safe.